Go. So when you're doing palpations, you're looking for 5 things. You're looking for obvious deformity, crepitus, pain or point tenderness, temperature changes, and swelling. So to start with palpations, you have your phalanges. On your first phalange, you have distal and proximal, and then 2nd through 5th, you have distal, middle, and proximal. Just proximal to that, you have the heads of the metatarsals. You have the head of the first metatarsal, 2nd, 3rd, 4th, and 5th. On the plantar side of the head of the first metatarsal, you have 2 sesamoid bones, which live in the tendon. Then coming back to the dorsal surface, you have the shaft of the first metatarsal all the way down to the base. Then you have the shaft of the 2nd to its base, 3rd, 4th, and 5th. At the base of the 5th metatarsal, you have the styloid process. Then just proximal to that, you have the cuboid. And then coming over medially, you have the lateral cuneiform, the middle cuneiform, and the medial cuneiform. And then proximal to that, you have the navicular. Then you have the talus and your calcaneus. You have the medial malleolus, the lateral malleolus, your tibia, and then your fibula. On the medial aspect, you have your navicular tubercle, then you have your sustentaculum tali, and then your medial tubercle of the talus. You have your calcaneal tuberosity on the posterior aspect, which just superficially you have the calcaneal bursa. Then deep to that, you have the Achilles tendon, and then even more deep to that, you have the retrocalcaneal bursa. Then coming over to the bony landmarks on the lateral side, you have your peroneal tuberosity, and then if you have them plantar flex and invert their foot, you have your peroneal trochlea. Then if we move on to ligaments, on the medial aspect, in between your navicular tubercle and the sustentaculum tali, you have your spring ligament, which helps to support the medial longitudinal arch. Then you have your 4 deltoid ligaments. You have your anterior tibio-talar ligament, your tibio-navicular ligament, your tibio-calcaneal ligament, and your posterior tibio-talar ligament. Then on the lateral side, you have your 3 lateral ligaments. So you have your anterior talofibular ligament, which lives in the sinus tarsi. You have your calcaneofibular ligament and your posterior talofibular ligament. Then if we come to the plantar surface of the foot, you have your plantar fascia, which attaches from the medial tubercle of the calcaneus and then comes down and attaches to your metatarsals. If we look at the muscles on the plantar surface of your foot, you have your abductor or abductor hallucis on the medial aspect. On the lateral aspect, you have your abductor digiti minimi, and then in between the two, you have your flexor digitorum brevis. Coming to the muscles of the anterior compartment, you have your tibialis anterior, and if you have them dorsiflex their foot, you can see the tibialis anterior tendon on that medial aspect. Then you have the extensor hallucis longus coming to that first toe, and then your extensor digitorum longus to the 2nd through 5th. Then on the lateral compartment, you have the peroneus longus, which comes down and wraps underneath the foot. You have your peroneus brevis, which comes and attaches to the styloid process of the 5th metatarsal. You also have down on the dorsal surface of the foot your extensor digitorum brevis that comes right through here. Then in your posterior compartment, you have your gastrocnemius and your soleus, which converge down into the Achilles tendon. Then you have your tibia in the deep posterior compartment. You have your tibialis posterior, which comes down and underneath the foot. Then you have your flexor hallucis longus, and then your flexor digitorum longus for digits 5 or 2 through 5. Then you have your dorsalis medius artery in between the first and second metatarsal. And then you have your posterior tibialis artery, which is just inferior and posterior to your medial malleolus. On this side, you have your sinus tarsi, where your anterior talofibular ligament lays. Then we're going to move on to you have your retinaculum. You have your flexor retinaculum on the medial aspect. You have your superior and inferior extensor retinaculum, and then you have your peroneal retinaculum on the lateral side. Then we're going to move on to manual muscle tests. When you're doing manual muscle tests, you grade them on a scale of 1 to 5. 5 being they're able to go against your full resistance against gravity. 4 being they can go against mild resistance against gravity. 3, they can go just against gravity with no resistance. 2, they're able to go with gravity and no resistance. And 1, they're unable to go even with gravity, and you're thinking there's a possible tendon rupture. So when we're doing manual muscle tests, first we're going to test the anterior compartment. So what we're going to do is we're going to have her start in plantar flexion. I'm going to support at the ankle, and to test the tibialis anterior, she's going to pull her toes up towards me for a concentric test. Then if we want to test the extensor hallucis longus, I'm going to support her at the midfoot. She's going to hold up into that extended position and not let me pull her down, and that's an isometric test of the extensor hallucis longus. And then we'll do the same thing for the extensor digitorum longus. So I'm supporting her at the midfoot. She's going to hold and not let me pull her out of that position. Then to test the peroneus longus and brevis, or the lateral compartment, we're going to do an isometric test where I'm going to support her at the ankle. She's going to pull her foot into that everted position, and then she's going to hold it there and not let me push her back into that neutral position. So that tests the peroneus longus and brevis. Then to test the tibialis posterior, we're going to do an eccentric test. So she's going to come into inversion. I'm going to support her at the ankle. She's going to resist, but let me push her back into that neutral position. Then in order to test the rest of the deep posterior compartment, I'm going to support her at her midfoot. We're going to do an isometric test of the flexor digitorum longus. So she's going to flex her big toe down as best she can. She's going to hold it down there and not let me pull her back up. Just like that. And then to do the flexor digitorum, she's going to flex her second through fifth toes down and not let me pull her back up. Then we're going to test the gastrocnemius, or the superficial posterior compartment. So we're going to start in that plantar flex position, and then with her leg almost straight, and then she's going to resist and not let me push her back into dorsiflexion. Then to test the soleus, we have them bend their knee to 90 degrees to take the gastroc out. We're going to again support the ankle. She's going to be down in that plantar flex position, and I'm going to try and pull her back up to test that soleus. After the manual muscle test, I'm going to have her slide back on the table so we can do range of motion. We're going to start with active range of motion. So in order to do range of motion at the ankle, you're going to have your stationary arm run along the fibula. Your axis of rotation is going to be right on the lateral malleolus. The movement arm is going to be parallel to the fifth metatarsal. And if we want to measure plantar flexion, we're going to have her point her toes down as far as she can. Move the movement arm so that it is again parallel to the fifth metatarsal. Then you're going to read that number and have her relax. Then to measure dorsiflexion, she's going to pull her toes up towards her nose as far as she can. Again, move that movement arm until it's parallel with the fifth metatarsal. You're going to read that number and have her relax. In order to measure inversion and eversion, you would have the patient roll over onto their stomach. You would have the stationary arm bisect the heads of the gastrocnemius. your axis of rotation would be directly between the medial and lateral malleolus, and then you would draw a line that bisects the calcaneus, and that's kind of where you're going to move your movement arm when she either brings her foot in for inversion or brings her foot out for eversion. So you would have her obviously bring her foot in and then move your movement arm to match that line on the calcaneus for an inversion read, and then have her bring her foot out and move your movement arm to match that line for an inversion measurement. So after range of motion, we're going to do special tests. So I'm going to have her come back to the edge of the table. So to start, we're going to do an anterior drawer test. So I'm going to grab the medial aspect of her ankle. My other hand is going to come underneath and cup her calcaneus. Then what you're going to do is have her in plantar flexion, and then you want to try and bring that calcaneus so that it translates anteriorly. A positive test for this is going to be increased laxity compared to the other side, or you can look at that sulcus, where the sinus tarsi is, to see if that sulcus increases as you translate the calcaneus forward. This implicates a potential anterior talofibular ligament sprain. The next test we're going to do is the inversion stress test. So again, you're going to support the ankle, you're going to cup the calcaneus, then move your hand just slightly lateral on the calcaneus, and then what you're going to do is you're going to try and invert them, try and put in stress in those outer or your lateral ligaments. A positive test for this is going to be increased laxity compared to the other side, and this implies a potential calcaneofibular ligament sprain. Then for the eversion stress test, we're going to do the same thing, except for you're going to switch your hand placement, and then your hand that's cupping the calcaneus is going to move to the medial side. We want to bring them into slight dorsiflexion, and then evert their foot, which stresses the deltoid ligaments. A positive test is increased laxity compared to the other side, and if a positive test happens, that implies a potential deltoid ligament sprain. Then we're going to do a Kliger's test. So you're going to change your hand position so that you support and stabilize the tib fib, and then your other hand is going to grab the midfoot. Then you're going to bring them into dorsiflexion, and then you're going to externally rotate their foot out. A positive test for this is pain in between the medial and lateral malleolus, and potentially up through that interosseous membrane that's between the tibia and the fibula. Implications for this, of that pain, is a potential anterior tibiofibular ligament sprain. Then I'm going to have her slide back onto the table, and we're going to do a fibular translation test. So you're going to have them come up into dorsiflexion. You're going to grab hold of the fibula, and you want to try and translate it anterior posteriorly. A positive test for this is either hyper or hypomobility and pain. If they have any of these, it's a possible sprain of that interosseous membrane between the fibula and the tibia. Then we'll do Tinel's sign. So what you're going to do is you're going to be tapping along that tibial nerve on the medial side of the ankle, and what you're looking for is an increase in either numbness, tingling, or a burning sensation, and this could imply a potential tarsal tunnel syndrome. Then we're going to do Holman's sign. So you would have them bend their knee, you're going to bring their foot up into dorsiflexion and squeeze their gastrocnemius, which a positive test is point tenderness and pain, and depending on the patient's recent history, you can either rule in or rule out a deep vein thrombosis. Then I would do the Thompson test, so the patient would lay on their stomach. You would squeeze the gastrocnemius, and what you're looking for is plantar flexion. If you squeeze the gastrocnemius and there's no plantar flexion, that indicates a positive test, which implies a potential Achilles tendon rupture. And then we're going to do a squeeze test. So if you're thinking that they may have a distal fracture of the tibia or the fibula, you would start more proximal and you would squeeze down the leg. A positive sign for this is pain at an area other than where you're squeezing, and this could imply a potential fracture. Then the other fracture test we do is called a bump test. So you bring them into dorsiflexion. You're going to take the heel of your hand and just tap against their heel, increasing the pressure of the taps as you go. A positive sign for this is pain at a location other than where you're bumping at the heel, and this can imply a potential fracture. So then we're going to do a neurological screen. So when we're doing a neurological screen for L4, you're going to look at the medial lower leg for your dermatome, and what you want to have them do for all of the dermatomes is distinguish between a sharp or a dull point, or if you're doing 1 or 2, you're going to have the patient close their eyes and tell you which leg and what sensations you're trying to have them differentiate between the two. So for L4, you're going to be testing that medial lower leg. For L5, you're going to be testing the dorsal surface between the first and second metatarsal. For S1, you're going to be testing that lateral aspect of the foot. And then for S2, you're going to be testing the gastrocnemius as well as the hamstring. So once you've completed your dermatomes, we're going to do myotomes, which is essentially an isometric break test. So if we wanted to test L4, we're going to do a dorsiflexion break test. So bringing the foot up into dorsiflexion, you're going to support the lower leg by holding at the ankle. She's going to hold that dorsiflex position and not let me pull her back down. So that tests L4. And then to test L5, you're going to grab the midfoot to help support there. She's going to bring her first toe up into an extension. She's going to hold it there and resist and not let me pull her back down. So that tests L5 for the myotomes. And then for S1, you're going to have them come out into eversion. You're going to support the ankle on the opposite side. She's going to hold that everted position and not let me push her back into neutral. And then lastly for S2, they're going to have their knee in that flexed position. They're going to try and hold there and not let me pull their knee back into that extended position. So that tests S2. After myotomes, you're going to test reflexes. So in order to test the reflex for L4, you're going to find that patellar tendon and then just give it a nice little tap. And what you want to see is their leg kind of kick out almost to it in a slight extended position. Then to test L5, you're going to grab the lateral aspect of their ankle. You're going to find the tibialis posterior tendon, which is just inferior and posterior to the medial malleolus. You want to give that just a nice little tap, and you should see a slight movement into inversion to test that L5 reflex. Then to test the S1 reflex, you would have the patient lay on their stomach, and then what you're going to do is you're going to tap the Achilles tendon, and you want to see a slight plantar flexion. Then to test S2, you would again have the patient lay on their stomach. You're going to start with their knee in a flexed position so that you can find that biceps femoris tendon on the lateral aspect. You're going to place your thumb there, and then you're going to tap the reflex hammer on your thumb, and you want to see the knee flex. And then after you've done S2, we're going to check blood flow. So we're going to check the pulse at your dorsalis pediis artery, so in between your first and your second toe, right there. Or you can check your tibialis posterior artery, which is inferior posterior to your medial malleolus. And lastly, you can do a capillary refill test. So what you're going to do is you're going to push down on the nail of your first phalange, and you want to count the seconds till the pinkish color returns. You want it to be between 1 and 3 seconds. And if it's not, you may have a potential blood flow issue and they should be taken to the hospital.